Welcome everyone. Thanks for joining us at the Oxford Psychedelic Society. You've joined the Varieties of Healing panel. Our committee members Sam and Pedro have kindly lined up quite a panel to discuss the various ways that psychedelics have been used, are being used, potentially will be being used for healing in the years and decades to come. We are joined today by Hanneke Schots, who is from Guided Tripping in the Netherlands, where I'm sure most of us here will know psilocybin is legal in the form of truffles. So she's a psychodynamic therapist who uses psilocybin in her work. Dr. Joe Tafur has trained both as a physician and as a curandero, which is roughly a healer. He's helped set up an ayahuasca retreat in Peru. Joe? And so he's written a book on the interface between Western and Shipibo medicine in his book, The Fellowship of the River. And last but not least, Professor Guy Goodwin is Professor Emeritus of Psychiatry here at the University of Oxford. He was formerly president of the European Colleague of Neuropsychopharmacology. He's listed as the principal investigator at one of Compass Pathways trials. And perhaps his proudest achievement, he is the senior member of Oxford Psychedelic Society. Before we jump into things, I think it would be good if we just hear a little bit from each panelist about how they came to work with psychedelics in their professional lives. And I understand Joe has a short presentation as well. Hanneke, tell us about how you got into this space.
Well, it started with my own experiences, of course, when I was 21, so that's a while ago, and it was recreative on a festival, but it was amazing what it did for me. I won't get into that now. And I've actually have been using it myself once a year for sure to keep myself open, keep myself connected. And actually those experiences, those psychedelic experiences sparked my interest in therapy. Wow, there's so much to being human, and how and where. And so I love to explore it all. It was really mind and heart opening. And after years of being on the therapeutic side, still doing my own process with psychedelics, I met Miriam from Guided Tripping. I'm one of the 6 guides from Guided Tripping. And she heard my story and she said, come and join us. And for me, best of both worlds collided there. So I'm very happy I can do that. Now it's therapy that's actually sparking my interest in psychedelics again. So that's how I got into this.
Great. Guy?
Well, I was a student in the late 1960s, so my introduction to psychedelics was kind of in the first time around, as it were. I can't say that I was actually particularly positively influenced or negatively influenced. It was a recreational excitement, but it didn't really mean very much more to me than that, to be absolutely honest. So, full disclosure. My subsequent interest was in the serotonin system. So I was involved in research which identified the functions of 2 of the major divisions of the serotonergic receptor pathway. And we showed that they were involved in the management of depression through the conventional antidepressant treatments. So the 5-HT2A receptor, which we now understand to be the main target for the drugs that we call psychedelics, was emerged out of that work. And I remained interested in how it could possibly be used for therapeutic purposes. So most of the work that we actually did was not in humans at the time. Of course, we were completely obstructed, ironically, from doing research on these drugs. So that was, in a sense, not available to anyone at that stage. But I was always very interested by the possibilities for therapeutic effects. And purely by chance, I met George Goldsmith about 4 or 5 years ago, and we were discussing the potential role of psychotherapeutics in particularly treatment-resistant depression, and reflecting that it was ironic that it was possible to be euthanized for depression, but it wasn't actually possible to be treated with a psychedelic. And at that stage, he was starting on his particular journey to raise funds and think about how to get psilocybin specifically into medical practice. So I was a sort of advisor to him along on the clinical advice on, you know, what it took to get regulatory approval and that kind of stuff. So I've been on that particular road with him for a while. I don't have a close association with the company, so don't have a commercial interest. But I've remained in contact, and we remain interested in the work that's going on. And I, as you've indicated, Eddie, I was the PI, principal investigator in the trial, the phase 2 clinical trial that is ongoing, will be completing later this year for treatment-resistant depression. So I'm a psychiatrist, so my interests are very much defined by clinical application, and I'm also reasonably experienced in how you get drugs licensed through our conventional licensing pathways. And that's really my perspective. So it's rather different, I think, from my colleagues, but you know, it's part of the picture that I think we need to understand around these drugs.
Absolutely. Joe?
Yeah, I don't have a presentation because you said it was better not, so I just introduced myself. Yeah, I got into as a medical student in the United States in San Diego. I kind of went through a depression. You know, I was kind of having a hard time, and my father is a psychiatrist. Grew up around a lot of psychiatrists, and you know, at some point he offered me some antidepressants. Many people in medical school were taking antidepressants to get through the experience. It's kind of common, and I don't know what you hear about the US, but it's flowing over here. And yeah, like a really unusual percentage. And so I tried it, and I did receive some benefits from that, but I didn't really want to continue that. I was interested in something more natural, or I didn't, you know, I just wanted to move forward somehow from that. And so I decided to go back to where I'm from in Arizona and go through peyote ceremony, you know, plant medicine, like sacred plant medicine ceremony. The Native American tradition in the United States has led to that, the ongoing tradition of peyote ceremony. And I had an amazing experience. You know, I had a really profound kind of healing and a shift in where I was at, and kind of had the strength and resolve to continue and finish medical school and finish my training. And then I went back to that a few times, and then my family's from Colombia, South America, and my grandfather's best friend was a medical botanist that had done a lot of traveling to the Amazon in the early days. And as it turns out, was one of the people that helped lead Richard Evans Schultes, you know, into the Colombian Amazon. And so I had been exposed through him about this, the ayahuasca, what they call yahe in Colombia. I knew that it existed. And I knew that I was so curious about the peyote and the peyote ceremony and how they're utilizing it in the tradition, that I wanted to go and try ayahuasca, you know. So after I finished my residency, I went down to Peru, and I had big experiences there. And so my, you know, primary background is, I was on the spiritual practice, that side, the ancestral tradition, you know, which I guess is to some degree is the origin of psilocybin work and all that. So in other words, the spiritual, the unabashedly spiritual side, as to, you know, the papers are being published, very important. I'm part of the Modern Spirit Epigenetics Project, where, you know, evaluating biological mechanisms in the MDMA psychotherapy research happening in the United States. I'm very interested in that. But the inspiration for that research project and the impetus and the money from all of that is coming from, you know, work with sacred plant medicine and Shipibo ceremony, like, period. And we were getting results, and the results are very positive so far. So that's where I'm coming into it. And yeah, but I'm also part of the movement in the United States, interested in the medical clinical side, the research side, and the other opportunities, you know, decriminalization, et cetera.
Great. I feel torn in 4 different directions about quite where to jump in first. But Joe, I couldn't resist the fact that, well, you raised a really interesting word, that you spoke about these medicines as sacred, which completely makes sense in their indigenous ontologies, but raises something of a challenge for the Western medical model. I wonder if you could speak a bit to how you could see these medicines being translated to like a largely secularistic, pluralistic, agnostic way of doing things?
Yeah, well, we understand that there's a lot of religious trauma, you know. There's this kind of aversion to the word spiritual or something like that is common, you know, in a lot of Western academic culture. Not so common, like in the Native American experience, et cetera. You know, there's really no concern. So then there's like, as we approach it with the research, et cetera, and then let's say focusing on the MDMA, this is psychotherapy research, we're just having the most kind of impactful, you know, influence in the United States. Psilocybin is there, it's coming along, but again, like the protocols, you know, I don't know, that comes into question, you know, how are they going to use it and what kind of results are they going to get, you know, ultimately, in other words, is there a way to use it in which you're going to get better results? So then, you know, the traditional perspective says, yes, you know, you need to acknowledge at the very least the emotional dimension of it, and then allow a space for some kind of mystical element, whatever you want to call it. And so then that becomes a semantic game, you know. So we respect people's hesitation and their belief system or whatever, or their dedication to not having a belief system, whatever that is, whether that is a religion in and of itself. But then this semantic game of, okay, we're starting to approach people's the mystical experience. So that's coming out of the psilocybin research, ego dissolution, you know, that drawing heavily upon meditation research in the field, you know, at the Imperial College of London, like the default mode network is drawing heavily on what we're learning from meditation, which is all, you know, mindfulness is a secular description of a, you know, millennia old spiritual practice. So we can't, it's kind of hard to separate it. So then as we look into the mechanisms and where these things are affecting people, then you have this, their sense of personal meaning, you know, what is meaningful in their life. So that's a term, that's a secular term that people find, you know, palatable. They're not offended by that. If we talk about personal meaning, if we talk about what they feel is significant, if we talk about then topics that are entering the research world, forgiveness, gratitude, compassion, that there's like studies designed now in the next generation. So just as we've been talking about before we came here, you know, this culmination, all this movement that's surprisingly fast, like in the ketamine assisted psychotherapy movement, like in New York, there's a group that I'm getting familiar with that's starting to do, you know, they're using this gratitude-based psychotherapy. And that's what's really driving the results they claim in their ketamine assisted psychotherapy. So gratitude-based psychotherapy, you know, has some relationship to the millennia old spiritual practices of this planet Earth.
Sure. And thank you for pivoting onto that word psychotherapy, because I think just putting a pin in this idea of sacredness for the moment, even just talking about psychotherapy, I think might raise some problems. Guy, so you've trained as a psychiatrist and you have some work in clinical trials development and drug developments. It strikes me that all of the sort of extra pharmacological factors that go into psychedelic medicine potentially cause some issues, or if not confusion, for mainstream pharmaceutical companies. Do you see that being much of an issue going from where we are now in phase 2B right the way through to potentially mainstream operation in the NHS, say?
I think that slightly depends on whether we can get better measures of outcome than we currently have. I mean, at the moment, it's entirely based on what people tell us about their subjective experience. And that's a traditional approach of psychiatry. But of course, in terms of how you show a benefit that will allow a payer to reimburse you for your treatment, there's an increasing pressure to show more than just subjective improvement. There's a pressure to show economic benefit, to show a reduction in charges to other parts of the health service. So I think the difficulty will be that because at the moment we're entirely based on these subjective reports, and the subjective reports, particularly with psychedelics, this is where the difficulty arises, are clearly influenced by what are called demand characteristics. You know, they're influenced by the fact that it's not possible to blind the patient to the treatment that they've had. In fact, that wouldn't, you know, that's almost antithetical to what you want to do. You want to make people as open to what is happening as possible and more aware of what is happening and what is different. So that I think remains a difficulty. At the moment, we're going to use conventional measures. We're going to, I think, the recent comparison of conventional antidepressants and psilocybin, which was published in the New England Journal, so that's maximally exposing the trial, that is the leading medical journal in the world. That is telling us that this is an equivalent treatment for the reduction of distress, and it's a more positive treatment from the point of view of well-being. Now, if that were borne out in terms that were fully objective, then I think you would be looking at the potential for reimbursement, for adoption by healthcare systems that basically have to look at the economics of what's being offered. Because these treatments are not going to be cheap. The drug is cheap, but the assisted care that seems to be part of the necessary treatment is not cheap. So in terms of comparing 25 cents a month of an antidepressant with something that's going to cost several £1,000s, that's going to be tricky for healthcare systems to justify unless we get clear evidence for superior efficacy. That's not at all impossible, but it's a new challenge which no other treatment has, or many other treatments have faced this challenge, but in psychiatry, they're going to have to move, I think, beyond purely subjective arguments. That's going to be a challenge.
Yeah, that's interesting. I suppose with psychedelics specifically, there are multiple hurdles that need to be jumped here. So at the moment, these are Schedule 1 compounds, which makes clinical treatment use of them nigh on effectively impossible. But I wonder about, so once a drug is licensed, say, all of a sudden you have more room for off-label prescribing and things, and also like once psilocybin will be the first out of the gates in the UK, I think, once that is no longer Schedule 1 and it can be prescribed, we do have to have these health economic conversations. And so one of the things that is going to be of interest to a lot of people in maximising availability, maximising accessibility, is the conversation about, well, who is it that we should permit to perform these therapies? Because very initially, it is going to be likely psychiatrists on the specialist register at the GMC. But Hanneke, since you are a practicing psychotherapist, currently working with psilocybin, I wonder if you could weigh in on this question of who should it be in the fullness of time that's permitted to perform these therapies?
So you're going to get my personal view here, yeah?
Sure.
Yeah. Okay, so I'm coming, being in the Netherlands where it's legal, I'm coming from the other side. Like, you know, everybody can actually just say, I'm a trip guide, I'm a psychedelic therapist, and come to me and we go and do this. Now, I don't necessarily, it needs to be totally like that, but I really do believe, I know quite a few people, they're fantastic in what they do, they're fantastic in their guidance. They're not a psychiatrist, they're not a psychologist, they are therapists, they've been in the self-development world for a long time, and they do beautiful things. And I strongly believe, especially psychedelics, they're mind-opening, heart-opening, more to come in, not the narrowness where you live your daily life in. And I also believe that in how people can offer their guidance, can offer their support, when people can offer their therapy, that there is this possibility of a wide variety. Like body workers will work more with the body, you know, and every therapist will bring their own specialism weaved in. And you know, if we plant a field full with the same vegetable for years, it gets drained. Whether if we grow loads of crops of all different stuff, it keeps healthy, it's fruitful. So I think a lot of people should be able to offer this, But I do think it's important to weed out the people saying, oh, I tripped 5 times and they're totally passionate about it, and then come to me. Like, I do think it's important, you know, about transference and counter-transference, because there's a lot of projection going on during. And also being able to sit with your own comfortability and, you know, because stuff happens, you know, and you need to be able to hold space for yourself and for the client. And yeah, if you have some idea of therapy, that's only helpful.
Guy, I don't know what you make of this. So considering this health economic consideration, how widely should we permit the training of psychedelic therapists? It's been a common theme in the UK. There's been this sort of neoliberal march towards outsourcing certain specific tasks. So now we don't just have teachers, we have teaching assistants. We don't just have physicians, we have physician associates, not just nurses, but nursing assistants. Is there any space in your eyes for a diffusion of the people that are able to administer this therapy?
Well, I think you need to distinguish a little bit between people who prescribe it, who make a medical judgment that this is a safe thing to do, and those people who support the person through the experience. I mean, if we take the imperial model, and indeed if you take the MAPS study with MDMA, these are not particularly expensive personnel. I mean, Roland Griffiths refers to the people who support his patients as sitters, you know, people who actually sit with the patient during the psychedelic experience. I'm talking particularly about psilocybin. It's a little different with MDMA because people are much more accessible. But basically those are not expensive staff, and they're not highly trained staff. I think there's a secondary question about who does the psychotherapy, which Hanneke is obviously referring to, which is not necessarily as time consuming as the actual sitting with the patient, because that is quite expensive. That makes an expensive day. I know this sounds terrible to be talking about money, but the truth is that I think the most likely outcome of what's going on at the moment is I don't think Schedule 1 is a barrier. I mean, after all, other Schedule 1 drugs can be prescribed. I think it's quite likely that the drugs will be licensed. And I think the issue will be access. And it's quite possible that this will be available in private practice before we really can turn around. I'd be very surprised that that isn't the case. But the difficulty will be how you reimburse this in socialized systems, and whether that is going to be particularly difficult. And I think, unfortunately, that it may well be in our system because of this monopoly payer and the fact that it's not a very flexible system. It finds a lot of trouble adapting to change. So I think we have a particular problem in the UK with this, but I think overall, you know, the principle is not so difficult to see that if this is a drug that makes new connections in the brain easier, which is kind of what is believed at the moment, then in a sense, any psychotherapy, which in essence is relearning associations. So that if you come down to what psychotherapy is, it's about changing the fixed patterns of association that you have in your mind. If that is what psychotherapy is doing, and this makes it easier to do it, then the point that Hanneke is making is that any kind of psychotherapy may, if it's an effective psychotherapy, be facilitated by psilocybin. Seems to me quite plausible. And that the people who will most benefit are the people who are most stuck and who are most chronic and who are finding it most difficult to resolve things using conventional approaches. So, you know, I see that in a very positive way. That's the promise of this drug, of this class of drugs. The delivery is what I kind of agonize about, because I can see it going into a private practice model much more easily than it goes into a public health model.
No, absolutely. I think it most likely will be the case that in the UK we will see, as we've seen with ketamine-assisted psychotherapy, Ben Sesser's Awaken. I think there'll be a good 24 before. Well, to quote Dr. Sesser on this, he sees himself in part as stimulating the demand and demonstrating proof of concept and efficacy. But Joe, there was just a very brief hint of a conversation we had before we let the crowd in. On this topic of who should be permitted to perform the therapies, what sorts of regulations should be available in the context of California's bill SB 519. Do you have any thoughts on who should be permitted legally to do this sort of work?
Yeah, well, I just one little quick comment I want to throw out there was just that, Guy had been talking about biological mechanisms. This epigenetics research that we're doing there is an interesting area that is really exciting. And like, in other words, how do we assess mental health improvement or the effects of emotional trauma that may be contributing to these association, whatever these problems are, and how do we sense whether it's shifting? And we are seeing that in the PTSD study. So I think there is room now for biological mechanisms to begin to be explored in the world of mental health and around efficacy. So that's one thought. Uh, Concerning people practicing, I just think that I understand, and there, we should all be concerned and be responsible and concerned about harm reduction and all of those things. That being said, like I said, I'm coming from a Colombian background, Peru, where these things, obviously they have a lot more cultural experience, so in other words, children are educated at a young age, some degree of, oh, what is this? Watch out for this. There's a lot of, bad guys over there, be careful. All that kind of stuff. So there's a cultural education, ultimately, I think that needs to happen. So that's happening. And so for us, but there it's legal ultimately. Mm-hmm. And I think if you look at the MAPS study, what they talk about is that really medicalization is the pathway to legalization. That's really kind of behind their movement. And that was coming from the marijuana movement. They wanted to see it legalized, that the criminalization and the criminal treatment and activity around it is kind of like not going anywhere. So like it's like clearing that up and being honest about that. And my family's from Colombia, so like the war on drugs, like the incredible failure that is for everyone involved. And so what really is to be gained, but we understand we want to protect people, we want to educate people. Is that happening now? These things are completely accessible, I think, in the United States, I would imagine in the UK as well, and Netherlands, no question. Anybody that wants to try it is trying it now with whoever is going to give it to them. So like bringing that out into the open and dealing with that. So I think that ultimately I'm for, like, the tradition that I'm a part of is yes, there is a responsible path to be somebody that offers ayahuasca ceremony. And it's a lot of training. And we believe that the person that is better trained and better experienced is going to give a much better result for the person. And that's a fact, That being said, so that people, they shouldn't, but still, I just don't know where the law and the criminality is impacting this in any positive direction.
Okay, let me propose something to you then, Joe. So it sounds like in Colombia, there are kind of cultural guardrails that mean that there's lots of harm reduction because people are broadly aware about who to go seeking.
To some degree, yeah.
But so my concern is that, say in the UK, US, Netherlands, when we don't have this deep, long cultural history of using these, that at least in the interim, personal use absolutely should be decriminalized. There's no sense in sending anybody to prison for doing these. But in the absence of a wide base of knowledge and understanding about who the best sorts of people to go to for this therapy are, maybe there should be some regulation, licensing, approval, even if it is just like a self-regulating unit as you see for...
I think that's reasonable. I think it's reasonable. And then it's also worth saying that meanwhile, the mushrooms are out there, and if people can't get it through their public healthcare system and they find a guy that's going to help them on the side, they're going to do that. They're not going to wait for the compensation of the system if they can afford to do it on their own. And so that will, so I'm just saying, and I believe that's like in the ayahuasca situation in the United States, getting it out in the open is the best way we can to protect against bad players. Leaving it in the shadows is where those predators lurk and the charlatans. Bringing out into the open, and maybe, yet it's fine to have some regular, whether that's just a guild or whatever. I think it should be. There should be some community standard, whether that's a legal regulation or community standard. I'm not sure how that looks. I believe in that. There should be a standard. The community is what determines who is, valued contributor in this field.
Sure. To jump back again to this theme of the health economic analysis, one aspect that's quite starkly different between, say, traditional uses of yahe in Colombia and say the clinical trials is how many people are undergoing this treatment at once, say. I wondered, Joe, if you could speak a bit about the group dynamic that's involved in comparison to, say, the one-on-one or rather two-on-one nature of
Well, and I
trials.
think just for the economic concerns, that's already popping up in the United States. There's MAP studies, MDMA studies. They're working on a group protocol. Many ketamine centers are already operating with a group protocol because of the economic situation, which similarly would affect the ayahuasca ceremony. If people are paying for that ceremony, they'd rather have a lot of people there to cover the cost. And so, so it's already happening. And so in psilocybin, I think there's already discussion around that developing. So I think that is one of the directions that it will go. I just, having personally experienced MDMA psychotherapy with the one-on-one treatment with the paired of therapists, very powerful, amazing, personal experience. So there's room for both, but if it's economically not viable, the group models, they are popping up already. And that is the tradition, is to do it in a group, at least with ayahuasca. And, there's ways to manage that and handle that and protect, people through that.
Sure. I think for psilocybin as well, is at UCSF, there was a trial of long-term demoralization in AIDS survivors that does a lot of group work. But I was wondering, Joe, is there any specific kind of clinical or therapeutic benefit to this dynamic of it not just being you that's journeying with the therapist, but the fact there is a socialized element to it, or rather a social element?
I think there can be, but I don't think one takes away from the other, So for us, the ceremony, the group experience, the way we do it, it's very powerful and very beautiful. But like I said, I myself am very experienced in that format, got so much out of so I just, the comparisons, it really will fall like away depending on what kind of benefit people are receiving. That's actually what's guiding this. Of course, yes, the regulations and all these concerns, cultural concerns, we have to deal with that. But the reason that it's flowering back up again is because people are healing with it. And so that's what's guiding it. And so then there'll be different opportunities for different people that will respond very differently. And that's a fact. And that's true in psychotherapy, that is very individualized. So this thought that this is going to somehow breed some kind of franchise chain is very unlikely from all of our experience with mental health, where not even the rehabs are able to maintain such a unified front in dealing with things. It's very varied, very personal.
Hanneke, I wonder if at this point you could talk a bit about your own practice. So you're trained as a psychodynamic therapist. If actually you could just spare us a minute to explain what that is.
Yeah. I'm trained in various forms of therapy, from the traditional hypnotherapy to inner child work, regression therapy, reincarnation therapy. And then there's various trauma therapies, amongst them is EMDR, that's one of them. There is more forms that work on the mental plane, like NLP, RED. So it's a combination, like it's up to me, I'm trained in these, and it's up to me to look like, hey, who is in front of me, the person, and what is the question, and where is the issue? Is it a troubled youth? Is it an incident? So that is kind of psychodynamic therapy. And there's talking, but there's a lot of experiencing as well.
Okay, so in your practice at Guided Tripping, is that solely one-on-one, or do you do group sessions?
We are specialized in one-on-ones. Yeah.
Why is that?
It's not like we like chose that. That's how it started, and we noticed we know people who do one-on-one, but groups was way more normal before COVID. And people came to find us and said, yeah, I was so overwhelmed and I want to do it again, but I got overwhelmed by the people in the group, or I couldn't hear myself, or I'd like to do it in a more quiet space. And saying like, like what Joe says, you know, for everybody, their own medicine and their own way. So we kind of stuck with the one-on-one, and it's going very well. There were already so many groups before COVID, we kept on going with that.
Sure. So one area of divergence, as I understand it, between the clinical trials as they're done currently and other practices of this therapy is the extent to which it's required that the practitioners themselves have experience, first-hand experience with these drugs. So Guy, I know it's not written into the procedures of the COMPASS trials that the therapist must have first-hand experience. Is that something that you endorse fully?
Well, I think it's pragmatic. I mean, I think they didn't have very much choice, really. That to make it a condition probably wouldn't have worked. So, I mean, the two groups who we're talking about, first of all, the sister group, and then the clinical psychologists, stroke psychotherapists, who tend to be the people who do the follow-up. There is no requirement that people have had previous experience of psychedelics. I think the truth is that because of the interest in the space, many of them have, but that's kind of not a requirement. I don't have a strong view on that, actually. I mean, I can see that it's a little like saying you have to have been depressed to treat people with depression, and that isn't really true. So, you know, I'd be open to being convinced, but I wouldn't start off with the assumption that has to be true. You have to have had this particular experience.
So in lots of psychotherapeutic models, it's sort of expected over the course of your training that you'll be kind of on the other side of the couch for 4 or 5 years just to have
in the psychodynamic world, yeah, not really in clinical psychology as now practiced. So I mean, if you look at CBT, that isn't really the assumption. Mindfulness, yeah, there is an element of that, certainly. But CBT, which is after all probably the main therapy that's offered by clinical psychologists, that's reimbursed, that's approved by NICE in the UK, that isn't the case.
No, it's not the case, but I do wonder if the introduction of psychedelics is going to force quite a reassessment, specifically of CBT and its valorization as evidence-based. But I think that's a big question, and there's a lot of guild interest in whether or not that gets disrupted. So we shall have to see. Joe, do you have any thoughts on this? I suspect you do.
Yeah, you know, I think typically so far, when you know, again, I'm more connected to the MDMA study, but I'm familiar with a little bit of the people that work on the Yale study, and I run into some of the others, and you know, so far for the research, they're handpicking people who have experience. You know, that's just a simple statement of fact, and so that they feel like that's, and they're getting the results. You know, so then back to the evidence again. Now they really feel as confident with somebody that hadn't been experienced. Well, they don't, you know, so far. They haven't wanted to bet their research funds on that. So there's that. And then there's what Guy had said. I mean, it's really in the US, it was just a matter of it wasn't really a choice, you know, to apply to the FDA and they've tried to include that. MAPS has tried to propose that they'd like to see that be part of the training, at least as not even required, but as an option. But that the regulatory commissions involved, you know, they haven't quite been ready to go along with that. So that's really
very recently they might have changed that.
I don't know. So I don't know if that's true. That would be interesting. I'm not. You may be more, you know, up to date than I am. But that's been an issue that they didn't. In other words, there was an initial resistance around this topic, so that the people behind this research wanted to see that be part of it, at least the option. So if they make the option available, I think it's back to the thing. It doesn't need to be required. I think the option should be available. You know, for us in ayahuasca realm, yeah, we drink it, you know, to run the ceremony, but you know, ideally the person is developing a deep enough connection with where they're trying to get to with the medicine that they don't need to drink very much anymore, or maybe they don't need to drink at all. So there has to be like something said about that. And so there are people who are extremely gifted, you know, in even in spiritual work, so to speak, who don't need to do it to achieve that. So I don't think the requirement is there. However, I think there's something to be said for the therapist that goes through therapy and all the rest of it. And that's, that's the traditional approach. And so then we talk about mental health care outcomes, well, yeah, it's not very exciting, the outcomes that we're having with this kind of epidemic of anxiety, depression, PTSD, and addiction. It's not very exciting. And so it's like, well, so does it need to be reevaluated? Of course it does. Is that one of the thoughts, that perhaps having the therapist go through the process, that could be very influential, in the culture? Yes. And I think there is an element of, and I respect it. I'm a doctor. I understand the process, but there's a real lack of vulnerability, within the academic class, within the, research medical class, that is difficult. It's very hard on those people. And so until they are held in such a space where they can be vulnerable, where they can be safe, where they'll be free from judgment, then they can kind of be able to enjoy what these other people are able to enjoy. But the pressures on them are very intense. So that's the support that we need. I think once people go through that, they say, yeah, you know what, this is probably useful.
Okay, at that point, I want to jump back from the medicine, back from the curandero, say, the healer, to the medicine. Because it does strike me, and this isn't a particularly novel thought, that ayahuasca in many ways seems like a complete anathema to the standard Western way of doing things, which is about very precisely defined doses, delivered the same every single time. Whereas, say, with ayahuasca, it's a decoction that's made afresh a couple of times a month, or sometimes ceremony by ceremony, and every ceremony, how much dose you get can be quite different. There have, of course, been clinical trials with what's called pharmahuasca, say just a source of DMT, a source of a monoamine oxidase inhibitor to mimic the most significant components of the ayahuasca experience. And to be honest, it seems to me, if that's going to get into Western clinical medicine, if ayahuasca is getting into Western clinical medicine in the next 15, 20 years, it will be pharmahuasca rather than the real deal. Is that a problem as far as you see it, Joe?
I mean, it's not my concern, really, because I get that if they want to do it and they're trying to do it, it just happened. These ladies proposed their FDA-approved trial at a conference, Sacred Plants Conference, put on by chacruna.net. And so they had the two women who were going to propose the FDA-approved ayahuasca trial from Hawaiian ayahuasca, and then counterpoint in the debate were two indigenous people from Brazil and Colombia who confronted them with, we do not want to see, we know what this is. This medicalization process is simply about commercialization. And for us, this is sacred. And we're asking you, no, please don't do this. Please don't run this trial. And so like the reality of those trials, or the pharmahuasca trial, or where that's going to get, where it's going to find traction or not, it's been puttering. It's been puttering. So there is research in Brazil. Brazil will be where that happens. Brazil, there's been research in ceremonial traditional use in Peru. And so that's going to grow down there. So as far as, getting into the northern climes, it's difficult to access, so I don't know that it'll be such an issue. Down there, they'll be dealing with that. But I'm part of the Church of the Eagle and the Condor here in the United States. So we're about the spiritual practice. So we feel like this, and so that's for us as far as dose and how do you deal with this is like, we've always done it like this. It's not just that. Peyote's always been done like that. It's not just that. The mushrooms have always been done like that. Psilocybin dosage, I guess for a couple decades, they've been looking at it. There's thousands of years. People are eating mushrooms in Mexico and beyond. And so it's just like, there's something to be said for that and the experience of that as to, is it true that this I've been in an ayahuasca ceremony very recently where the same dose of the same medicine creates an incredibly different response in the same individual.
Sure.
And these are realities of experience, so maybe when you publish the paper and, when that's the data that they want presented, in the publication, that's what the editors want to know. But how relevant is it in fact, to the degree of what happened is there's another issue there. What happened during those sessions? That is the pivotal event in the research, in fact. That's what makes this different from just a normal psychotherapy study, is not just the biochemical reaction. What happened to that person during that session? So that ends up being a real phenomenon that is a pivotal part of this whole experience. For us, spiritually, at the very least, emotionally, across the secular and spiritual realm, you know, the emotional side, the emotional biology involved, and then, you know, ultimately psychologically, etc.
Yeah, that makes sense. I think, so the issue with, well, one of the many issues transporting this medicine to the West is that there are all these extra pharmacological factors that we are very confident play an impact, both in terms of the experience, but then their clinical effect as well. And I
Very
think
confident, but then the
post-licensing,
Prozac, the SSRI studies are just flopping, you know, very confident because of a powerful campaign.
Sure. The point I was getting to is that post-licensing, once this is available, all of a sudden, once certain hurdles have been jumped, once certain hoops have been jumped through, all of a sudden clinicians have a lot more flexibility to fine-tune all of the elements of the treatment, including, well, music, context, any other ritualistic element, although probably not within strictly clinical spaces. We did just touch upon this issue of plants versus synthetics, which is something that riles up a lot of people in this community. Like a lot of people are very confident that it's only psilocybin mushroom, like it's only the full mushroom that gives you the treatment, which I find is a little overconfident, because we look at the clinical trials for psilocybin and none of them have been with the whole mushroom. They have been with the synthetic. I'm fairly sure Maria Sabina, when gifted the first bottle of Indosyme psilocybin pill, she was quite content with their mechanism of action. Hanneke, since your work solely involves truffles, do you think there's anything important that's gained from having the full spectrum of alkaloids? Or would you be quite happy 10 years from now giving people psilocybin pills?
Well, I'm fully with Joe. What I see is we start with 15 grams, and for some people this is totally enough, and other people need more. Like, it's so individual, the dose. And, you know, there's this talk about weight. That's sometimes that happens, but I also see like really skinny little women and they just take way more, you know. It's also how the person, how open they are, how they are not resisting, how they can let go. So if the end it's a pill or a truffle, as long as the working is there, great. I personally have a bit of a preference for nature, but I don't think the doses can just be set like, right, this is the doses and this is what needs to be. It really needs to be individual, looked at, experience. You go in contact with the person, and of course I look and we decide. Okay. So, yeah.
Guy, I'm curious if you have a horse in this race, beyond the very pragmatic issues of drugs needing GMP licensing. Do you have any sense, even if it's a gut feeling rather than like a hard-nosed empirical take, on the relative benefits of mushrooms versus synthetic psilocybin?
No. No, I don't have a horse in the race. And I think that just to reiterate that, you know, we face the wall of medical conservatism as far as licensing these drugs go. And, you know, it's just more sensible to go for something that is in some way recognizable to regulators, who are much more used to looking at drugs for cardiovascular disease, cancer, rheumatoid arthritis, etc. You know, the things they look at every day are very cut and dry. They're very concerned about safety. They're very concerned, you know, post-thalidomide regulation has been mostly about safety as well as efficacy. And so what they want is they want drugs that they know what's in the tablet, they know what the dose is, and they know what the cost benefit is in terms of efficacy versus adverse effects. Now, I think we're lucky that this class of drugs seems to be incredibly safe. So that's really fortunate. But, you know, you can't say that when you take anything that someone gives you that's not produced under GMP conditions, you really don't actually know what you're taking. And there's always going to be a sense within the conservative medical establishment that's not acceptable. So that, you know, I think it's the choice. You can go with the mushrooms, you can go with the natural way, you go for the health food shop, as it were, and that's fine. You've got a different set of legal arguments. If you want to go through this more medicalized route, then it's just going to be different. And you know, I'm not trying to decide which is better. I'm just telling you the way it is.
I will follow up with a question from the audience, actually from Raven, our former president there, Guy, who says, it seems like surely the ritual elements of the practice must add to the effects. Maybe by prescribing it in a clinical way, we're missing out on this. Given what you've spoken about in terms of the conservatism of the medical establishment, even post-licensing, do you foresee there being any space for adding these extra elements that are most foreign to
well, I mean, certainly at Imperial, they're already getting a bit cultish, I have to say. So I'm not sure that it's true that they're doing it in a very, very cold clinical environment. They're actually, and this is also true of Compass. I mean, Compass have taken a lot of trouble to standardize the environment, but they're very, very concerned with the sort of stimuli, the feel, the look of the place in which people take the medication. So it's certainly the case that there is concern about standardizing that as well. And I think it's also true to say that, yeah, the ritual components that are derived from other civilizations, fine, but our rituals are about medical care. And those are just as strong rituals, and they're just as reassuring for people in Western societies to see, you know, white coats and orderly looking wards and so on. That's our version of ritual. And, you know, don't underestimate that. The average person may actually value that as a reassurance that what's going on is safe and there to help them. Whereas stepping into something that is very unfamiliar, very exotic, may not actually be something that's reassuring to, you know, the average person who gets, you know, severely depressed in Huddersfield. Who knows?
Mm-hmm. No, I think that's very fair. Like, I think all of us who are here today are possessed of some privilege or another. Like those of us who have been lucky enough to go to Peru, Costa Rica, the Netherlands, somewhere where this is legal, are different, say, like I think to like my friends' parents in council flats in Birmingham who would be potentially beneficiaries of this treatment, but the idea of what they would see as quite exotic, quite alien practices would be the exact sort of stuff that would be like, no, thank you. That's even once we've gotten over the stigma of these are the bad drugs, like these are the illegal drugs. All right, since I've broken the seal on looking at questions from the Q&A, I will start seeing what else we've got here. Yuri has a question for Joe. What aspects of the ritual practice should we integrate into the clinical use of psychedelics?
Well, I think that the truth is that it'll be very dependent on the practitioner. So again, when you start talking about ritual practices, the standardization that, you know, it's gone. It's gone, by the way, and I'm a family medicine doctor in the United States. It's gone in high blood pressure treatment. You know, we have the standard dose, which Guy makes we need to know what's safe. What is a safe range? That's extremely important. But once that happens, blood pressure treatment just go down the range of any practice. What pills are they on? What doses are they on? Extremely varied, because everybody knows as a doctor that people respond very differently to these medications. You know, the studies are about averages. So that's there. That being said, part of what we're bringing forth with all this movement is and I agree with guys, you know, there's limitations and there's resistance because the movement supposedly, again, it's the research standardization, but that's not real. Okay, when you talk about psychotherapy, even CBT, if we go to every different office all day, spend an hour with each therapist, very different experience. So this idea of the organic, you know, returning our gifts as human beings to the medical field, you know, the healing arts, and just being honest with that, that's already going on. you know?
Mm-hmm.
Every doctor is different when you go. You don't send your mom to that one or this one. You want to know who it is. So when I had my friend who's 80, he's almost 90, you know, and then he has some connection to Oxford, and I told him, hey, I show him the link, and I see the logo, and you know, a little bit, oh no, how is he going to react, this old Englishman, to the logo? You know, it's kind of like the cat's out of the bag, you know.
Mm-hmm.
Look at the Oxford Psychedelic Society logo. It's already acceptable. And so they're just, I think it's just realizing that this kind of stuff, it grows and it's organic. And so that's okay. And it's going to happen because there's already the playlist. So who picks their playlist? You know, there's already so many elements. What kind of pillow, what kind of cotton thread do they put down on the bed? It's already so personal, and that's okay. And that's just the truth. And that's how it is. And that's how it's going to be. You know, so as far as what ritualized practice, it will very much depend on what kind of training that person has, what kind of gifts that person has, because once we bring those elements in, it really is about that person. Like, you know, which is just, it's true everywhere. You know, some surgeons are better with their hands, like, no question. You want that person. That's the one you want. So it's just, you know, there's a standard framework, and then there's the reality. And that's the world we're currently in right now.
All right. All right, get your crystal balls out, everyone. There's a question from Liam Donkin on Facebook. How long do you think we are away from mass/accessible psychedelic therapy? Hanneke, you can pick whether this is in Europe, the US, the UK. When does this become standard?
Wow. Well, I'm starting to get the sense here, because it's a bit of an explosion here, Wild Grow, that they want to cut it down. They want to, you know, the government, and they want to make it more safe. And so whether the rest of the world's been booming, I can't answer that question. I love how it's going in America. I love that the world is bubbling about it. And that's a really great thing. And I say, let's keep it bubbling and see how it finds its way.
Not getting a prediction while being recorded, that's fair enough. Guy, so we have things like the Oregon Psilocybin Initiative, which passed at the end of last year, which is planning on having, outside of the mainstream medical model, licensed therapists using psilocybin. And it seems like, at least in one state of the US, that will leapfrog over the traditional mainstream clinical trials like Compass Pathways are going through. Do you have any sense on whether that's a flash in the pan, or maybe do you think we're liable to see more initiatives like this in the US or even elsewhere before the medicines, the pharmaceutical psilocybin is ready?
Yeah. So it's a question of what Oregon thinks today, does the rest of the world think tomorrow? I simply don't know. But you know, you have to say that the marijuana example, cannabis example, suggests that once this ball starts rolling, it starts rolling very quickly, and that in that particular case, medicalization was pretty much of a veil which was quickly brushed aside in terms of full legalization. So I can quite imagine in the States that not all of the states in the States, but in many states, they may very well follow Oregon, since there's a sort of political side. I mean, the polarization in the United States means that, you know, you seem to get one thing or the other, and Oregon represents a particular kind of extreme Democrat version of life, and other states with that political persuasion may very well go the same way. I'm not in a position to really say, because I don't know. I'm not sufficiently in touch with the US scene, but that seems to me very possible, that it simply jumps over the regulatory hurdle and makes for the wild, as it were. And I think it's very possible that's what happens. In fact, I wouldn't be surprised if that's what happens in America. I don't think the same thing will happen in Europe, because we are more addicted to regulation, particularly the EU, and there's going to be, I think, much more of a likelihood that it proceeds along a more medicalized route. That would be my own guess.
Mm-hmm. One of the gifts of the US federal system, I guess, is that all these states can have these little experiments. There can be tighter pressure points for ballot initiatives, where of course in the UK there's nothing approaching that at all. It's going to look very different however it plays out here.
And it would be very good if states like Oregon had a careful register that actually followed up what happened to people and could show, you know, in the real world that there are good outcomes and that the drugs are safe. That would be great. But unfortunately, the US has a poor reputation for doing that.
I think there will be lots of interesting data coming out of Oregon, because all of a sudden you will have like a natural experiment with all of these things that need to be standardized in clinical trials. We will see like a plurality of different modes of providing this therapy. And amongst the noise, I hope some signal should come out of that. Hanneke, while we're talking about this Oregon initiative, one thing that's quite interesting in that, relative to the main discourse that's happening in psilocybin therapy, is that under the Oregon initiative, you don't need any clinical diagnosis. There are measures available such that you can have psilocybin therapy for personal exploration. And like beyond have it being diagnosed with general anxiety disorder or depression, if you come to a psychodynamic therapist anyway, like it's not necessarily because you have a diagnosis, it's because you have some problem in living. You might be unhappy with how you set boundaries in your personal relationships. You could come with all sorts of things that don't really register as causing a clinical problem. What role does psilocybin have for these, well, for healthy, normal people, but also for people that have psychological issues that don't quite fit into a DSM diagnosis?
I love this question, because these are also most of my clients, and it's very individual, so the working. So it doesn't, you know, has the same effect, and not everybody has the same results out of it. But what I've seen and experienced, there have been some really wonderful transformations, shifts, insights, and exactly around these things. Like people find them in patterns that keep on returning, like setting boundaries, like, you know, like I keep on being the pleaser, giving myself away, and later I'm angry with myself. And I've seen beautiful work around that. Also, I notice it works a lot on connection. So there's people who feel like, I have this wonderful family and I love my job, but you know, I always feel kind of lonely or isolated or disconnected somehow. I've seen beautiful, beautiful things happening there. And then we're touching also a bit on the spiritual side. You can land in a lot of different places on your journey. But if you reach this, like, everything is one, everything's connected, all is love, and people do have these experiences, you know, coming out, it's like, wow, I can go through states of feeling disconnected. But I had on such a deep level, a deep knowing of all is one. I cannot even really fully sink into that anymore. So I see great, great, great results. People who are more withdrawn, that open up. Quite often down there, you know, things have happened in their life. There is a negative conviction about themselves. It happened in a situation. Somehow they revisited that and saw it with adult eyes, and yeah. Great.
Joe, I am going to blend a question from the audience with one of my own. So Sam, who I think was kind enough to bring the three of you together onto this panel, says, the role of the religious, spiritual, mystic, divine seems to play an important role in the healing effects of psychedelic drugs. People with depression often suffer from perceived lack of meaning in their lives, and such experiences can allay these concerns. Do you think the secularization of psychedelic therapy, as would likely be required in the context of Western medicine, could hamper this effect? Or should Western medicine embrace the mysticism that comes with psychedelic experience as part of the therapy? And I will hold off on my follow-up question. What do you make of that, Joe?
Yeah, well, it's like, I get it. This idea that saying religious, spiritual, mystic, divine is somehow the language of a heretic, you know, it's so ironic. But I think it's already embraced it. That's what I'm talking about. All these research studies, like, for example, for me, because of my shamanic training and background, and then in the United States, in an effort to diversify these boards, and, you know, let's have Joe on the board to represent the cultural, spiritual side of this movement. And I get there, and I find that they are the people leading the cutting edge that I'm exposed to are the first to be curious and interested in the sacred and the ceremonial. That's my experience every single time. So I just think that it's already happening. And so because you know, it's very semantic discussion. I mean, so we said, okay, people perceive lack of meaning. That is a metaphysical statement. Okay. Like, we are in the realms of consciousness, you know, neurosciences, there's a lot of mystery in every moment of every second of, you know, us just speaking right now, of the way my brain functions. So it's just kind of like what you were saying earlier about the diagnostic codes. It's like, oh, you know, if they don't have a diagnostic code, but they have a problem in living. It's like, well, really, they have a problem in living, and then they gave them a diagnostic code. Why did they give them a diagnostic code? So that they could bill. It's a corporate product, okay? So then in the case of medical marijuana or all these other, you know, or even a mental health referral as the family medicine doctor, people are like, well, you know, I want to get a mental health referral, but then you're going to have to diagnose me. And then, oh no, what are you going to put? Then it's going to be on my record, and I don't want to be on. So then you come up with, you know, here's one, adjustment disorder. This is a billable code in the United States. Having emotional and behavioral symptoms within 3 months of a specific stressor occurring in your life, experiencing more stress than would normally be expected in response to a stressful life event, and or having stress that causes significant problems in your relationships at work or at school. So you had mentioned problem in your life. So that's an extended way to describe what we would call a problem in your life. And so like with the medical marijuana thing, that same thing. Oh, I don't want the wrong diagnosis. What can you give me? Okay, let's give them this one, so that they can get, you know, they can pass through the system. But the root of the issue, when they go home and they talk to their family and they talk to their loved ones and all this other thing, it's about this problem in life. It's about this perceived lack of meaning. So it's there, whatever we call it, you know. And again, I think we have to respect the religious trauma issue, you know, and all that. But it's like, whatever we call it, that's what we're talking about. You know,
Sure.
matters
Okay.
of the heart and soul is okay in a song. It's okay for the Beatles, but it's not okay for Oxford.
Joe, tempting as it is to pin you down on psychiatric neurology there, like, we only have 20 minutes left, and so maybe we can have a follow-up on that at another point. But I
thank
will,
you for having me. It's an honor.
We'll challenge you. Like, I think a lot of it isn't semantic, though, when we talk about this mystical, element. So something that I keep coming back to is thinking about the St. John's, the Johns Hopkins trial for tobacco addiction. This is where people had been smoking 20 a day for the best part of a couple of decades, multiple attempts to quit. Like, they really wanted to quit smoking tobacco so much they went on to this highly experimental trial. And you look at the qualitative reports afterwards, and what many of them said was that actually quitting smoking was the least important thing that happened to me as a part of this trial. So for a lot of people, it is, call it mystical, call it spiritual, call it, there, you have in some patients this ontological shock, this realization that, well, actually, things like the universe maybe doesn't quite operate in the way that I thought it did. Like, you come to this treatment for a very everyday concern. Like, of course, tobacco smoking kills millions of people, but it's not something that kind of takes over all of your life every moment in the way that maybe treatment-resistant depression or existential distress secondary to cancer does. So my concern, I guess, with this religious mystical element is bringing people into this therapy advertising it as being good for what ails you, but all of a sudden you are left holding the bag of, oh God, what is reality? What is the nature of my relationship to God, the universe, my fellow man? And I'm concerned about what should therapists say in the Western agnostic, secularist, pluralistic model respond. How should they respond to that? Because you have Matthew Johnson at JHU effectively said, oh, we'll keep context free on that. We're not going to impose our belief system on this, which firstly is problematic because it kind of suggests that you can never be context free, that you can never like just have a neutral blank on which the participant, the patient.
That's simply true, yeah.
But it seems like there's psychedelic therapists can unwittingly bring this whole new bunch of really profound, non-medical, strange questions that will take weeks, months, years for people to grapple with. Do you think that there's any responsibility for people giving out these medicines to help patients through this?
It's better than dying from smoking, first of all, to have an existential crisis and work it out. And there's, I feel like I'm going to screw up your name. Hanneke? Is that what it is? Is that correct? Yeah, I mean, she's there. There's so many people out there. There's so much integration work. I mean, that's the whole movement, is that, yes, in fact, what you're saying is extremely important, that the integration piece of, after potentially shattering somebody's reality, like that is a big risk. And that's a big concern. And so the context has to be there to help people work through these issues, which are potentially the same issues people are going through for normal mental health. I mean, I don't know, the psychotherapists are helping people through major life crisis, the death of a loved one. These things shatter people. And so, and by the way, they used to go to the priest or the nun forever to deal with this kind of stuff. So, I mean, we have experience in the culture to help people through issues of finding meaning in their life. It exists. And there's many, many people interested in this, and namely the ones that are drawn to this kind of work. And so, like, many people love helping people through that. I see that, Hanneke is there talking about bringing people into this universal love experience and finding, drawing upon probably heavily, all the experience of the world of how to help people deal with this. It's not like we're just, oh my God, we just found out that the universe isn't what we thought it was, that our conditioning could be, blown apart. And like I said, there's huge life experiences that happen to people without any psychedelics that are play a major role in people's mental health issues and development that we do try to address, trying to help people grapple with very difficult questions about their life. So I think we're prepared. I think there's a lot of people interested and prepared and trying to support this, and that it's actually quite healthy.
Hanneke, you are smiling and nodding along to a lot of that. I think you might have something to add.
Well, okay, so I think if a person only wants to stop smoking and for the rest doesn't want to change anything about his life and is very firm in that, then maybe you can send him to a hypnotherapist that specializes in that. Yeah. So there are other ways, and I do think it's good if this is suggested by a doctor or whatever, that you do give context. Hey, this is psychedelics. It alters your perception of reality. It's good to at least brief people, on the experience before, what to expect, what not. That's part of the setting you give people, right? And you have an intake call, where you address, where you talk, where you explain, or more than one intake, or where they can ask that question. So I think once they're ready to enter, they at least have an idea of an imagination, what they're getting into and what to expect. And the experience is always unique, especially the first time. But I think exactly that aspect is a lot of what brings the transformation around, and it's growth for people. Their narrow box gets broken and their world becomes bigger, and there's, they also feel held by this whole universe we're in, instead of I'm fighting it all by my own and it's all up to me. And Not that everybody has that experience, right? People can arrive in different places in their journey.
Guy, thank you, Hanneke. Guy, I wonder if you have any thoughts on this from your perspective. So you've spoken this evening about the value in the West of having this cultural container of the white coats and the clinic. Is that sufficient, as you see it, completely for the all of these very strange, for most people, first-time experiences of the dissolution of ego and all of the associated experiences?
That's tricky. That's a sort of loaded question. So well done. That's a good one. I think.
Oh, you noticed.
Personally, I think that my approach to this would be to say that actually this experience that you're going to have is actually less about the world and the universe and about your brain. And essentially, what we do is we create something extraordinary with our brains, and we still don't fully understand that. And that seems to me what I personally, if you want my sort of personal non-clinical interest in it, is that this extraordinary drug, which acts on a relatively narrow range of receptors, produces this extraordinary change in the way in which we process information. And information essentially is the kind of the missing part of physics that we don't really get taught about, but it's actually fundamental to everything that's happened in evolution and in terms of where we are now. But I don't personally buy into a mystical epistemology, so I don't find that very helpful to explain the world. But I do find it quite useful to think about how the brain works to understand what I see in the world and how I understand it. And I suppose it's very extraordinary that this drug produces the changes that it does. But many of those changes are going to reflect the structure and function of our brains. And that, it seems to me, the challenge for the neuroscience that is then certainly being stimulated by all of this stuff. We're going to get, and I think there's a question in the sidebar about their interest in consciousness. Well, there is a renewed interest in consciousness among neuroscientists, which has undoubtedly been given a big kick in the a kick up the pants by this kind of observation. So, there's the scientific approach, the idea that we use our rational minds to develop conjectures, to do experiments whereby we can test them. That's not exhausted by the phenomena of the psychedelics. In fact, it's a challenge to it, and it's a really interesting challenge to it. So that's my personal perspective.
Maybe you thought the question was loaded in a different way to the one I imagined. I wasn't trying to pin you down to a non-materialist metaphysics, and I don't necessarily disagree with you about everything you said. I think you can accept that the action of psychedelics is entirely neurological, and arguably this is important for the trials process and for integration into Western medicine. But that seems to me a distinct question from how you discuss these issues with patients, because even if it is just some manifestation of brain activity, that you have this noetic quality, this sense of it being unmediated awareness that the universe actually isn't like that. It seems like it would be cold comfort to be told, no, that's just something your brain did. Or and I'm not even sure to what extent, is it Bernard Williams talks about like doxastic involuntariness, like you can't really choose what you believe on the basis of the evidence that you have. And the issue is that with lots of these psychedelic experiences, doesn't matter if you're a card-carrying materialist, you just know that that's not quite how it is. So like, what sorts of conversations do you think should be happening with patients?
I suppose all I'm saying is that there is actually virtue in having conversations with patients about scientific explanations of their state, about how we understand they get to the position that they're in, how we think some elements of the brain works. And for some people, that's really quite a helpful way to reframe it. And it gets them out of circles of guilt and concerns about meaning and so on, which, often come down to really hard questions, which are very, very difficult to answer, perhaps impossible. Why are we here? It's a big question. I mean, the hard question of consciousness, no one's come up with an answer to that. So I think if you're wanting to really help people to think about their situation in a clinical setting, you don't do them any harm by thinking about how you can understand it using our, as I say, rational means of hypothesis and conjecture.
Mm-hmm. I think there's sort of an abundance of options at the moment, given how early on we are in actually understanding what these are. There's a plurality of models that can be wheeled out, and patients to some extent can take their pick to see what resonates with them. Apologies to Taylor Bennett, who I think asked one of the first questions. Are there risks that big pharma will overexploit plants and fungi that have indigenous cultural significance? Guy?
No, big pharma are incredibly conservative, and they wouldn't take any chance like that. I mean, if this became something that was part of the health food industry will produce plant-based stuff, and you can go into Holland and Barrett any day of the week and buy it. So if it gets to that point, then there will be that kind of commercial exploitation. But big pharma really are interested in novelty and things that they can patent and keep under patent for 25 years. And that's not possible for plant-based medicines, or indeed for many of the drugs we talked about tonight. That's one of the difficulties that I see for the whole pharma model, which we haven't really got onto. So no, I don't see big pharma as a particular problem in this at all. They're not going to be very interested. Little pharma is interested, and there is some innovation in this space to try and produce new entities. Big pharma may or may not be interested, depending on what the results look like. But big pharma at the moment is very much on the sidelines.
Joe, what do you make of that question?
I think, guys, that sounds like a very clear assessment of the situation. In other words, the plant medicine track, or the psilocybin, the truffles, they can continue on their own. And I don't know. I mean, marijuana, I guess everyone's worried about marijuana taking over big corporate production. There is discussion about, in the United States, of people trying to do, mass production of psilocybin mushrooms, and all the venture capital money trying to move towards that. So I think there's going to be attempts to take over the market in just kind of a capitalist fashion. But at the same time, so many people can grow mushrooms at home, and it's all this, I don't know, the marijuana, I don't know, the beer, the microbrew business is booming in the United States. I don't know how it is with the ales, but it's just, there's really, they thought they were going to take it over, but turns out Budweiser is just not that, up everyone's alley, or they want to try something different. Turns out wine has gone down a much longer trajectory, and no one's really cornered the market there either. So I don't know. I think there's room for diversity around with this stuff, and I'm not sure what's going to happen. I understand the threat of big pharma and people's concern about the system, et cetera, impinging and destroying everything in its path. But I think still, we're trying to thrive as a human society on this earth. That is another force in the mix. It's not just them and everything that's coming down the pipeline. There is this other force.
I'm sure many of the people in the audience will be aware we had quite a big conversation 1 or 2 weeks ago between Alex Bina and Lars, I can't remember his surname, from Compass. And I think the video of that is already on the YouTube channel for OPS, or will be shortly. I'm conscious that we are coming to the end of the discussion. Lars Wild it was, thanks Yuri. So I just want to alert people to the fact that we're very pleased that you could join us, but we did, as always, put on this event for free. We do have some minor running costs, so if this has been worth £1 or £2, I have just dropped the PayPal link in the chat. I think it might be good to just offer each of our speakers an opportunity for some closing thoughts, get off their chest anything that we didn't discuss. Joe, what's your book called again?
My book is called Fellowship of the River. I want to let people know about the Modern Spirit Epigenetics Project, epigenetics analysis of the MDMA-assisted psychotherapy trial, which is very exciting. And we're the Church of the Eagle and the Condor, United States, trying to navigate a way for basically me to practice ayahuasca ceremony, which we believe to be sacred in the United States, and to get the exemption that the previous organizations have gotten. That's what I'm doing. That's what I want to share. Thank you for this. It was a great opportunity. Very interesting discussion.
Thank you, Joe. Hanneke?
Yeah, I just want to thank you all. I found it really, really interesting. I also heard very, like, Guy's points. It's really interesting to me, because that's not something I normally get acquainted with, like just thinking the brain. So I love it. I love that input too. And yeah.
Brilliant.
Thank you.
Thanks for joining us, Hanneke. And Guy?
Well, thanks as the senior member of your organization. I'm always very flattered to be, I thought I just signed the checks, Eddie. But it's a pleasure to be here, and the field is a very interesting one, and let 100 flowers bloom. There's not just one way to see this.
Yeah,
great,
absolutely.
Great conversation.
Yeah, hopefully the future of psychedelics is quite open and pluralistic. So our next event is Psychedelic Breathwork at 7 p.m. On Thursday, the 10th of June, followed by Accessing Other Dimensions on DMT, with a kind of all-star cast for that. Rick Strassman, Andrew Gallimore, and Chris Timmerman are joining us on Monday, the 14th of June at 14:30. If all of you could just unmute for a moment so we could give a round of applause to our three panelists. Thank you so much for joining. It's been great. I mean, it never sounds very impressive when you do that little applause at the end, but I'm sure everyone enjoyed it. Thank you, everyone. Good night.
Cheers now. Bye-bye.